Good afternoon, everyone. Welcome to our next session in our geriatric bootcamp. This week, we are in week 2. We're going to be talking about post-operative management of the older adult. With us today, we have Dr. Nadia Mujahid, who is an associate professor of medicine at Brown University and is also the co-director of the geriatric fracture program. So we're thankful to have Dr. Mujahid here with us today. But before we get into today's topic, we do have a couple of housekeeping items we'd like to get through. So if you're not familiar with who the iPro QIN-QIO is, iPro holds the federally funded Medicare QIO contract shown here for the region. iPro specifically helps support New York, New Jersey, and Ohio. Health-centric advisors help support Connecticut, Maine, Massachusetts, New Hampshire, Rhode Island, and Vermont. And Clarent helps support Maryland, Delaware, and the District of Columbia. So together we are 3 organizations under the iPro QIN-QIO banner. If you're not familiar with any of us, health-centric advisors or iPro or Clarent, you are now. And if anyone asks if you're working with iPro, you say yes. And at this point, I'd like to pass it over to Mary Ellen Casey, our subject matter expert in infection control. I know everyone keeps saying that COVID's over, but I know that there's been actually a bit of an increase that we're seeing across the country as well. So over to you, Mary Ellen. What do you have for us?
Thanks, Josh. Yes, that's true. It hasn't gone away, but I would guess a fair amount of folks on this call know that and have been dealing with it. Hospital admissions are up 3.11 per 100,000 cases. This is as of the 5th of August, the data there, which is an increase of 14.3%. We've had an 8.3% increase from the prior reporting week for deaths as of the 12th of August. And these cases that we're seeing in the hospital primarily impact the age group over 75, which again, no surprise to this group. With the fastest growing cases of confirmed cases are actually in the long-term care facility. So something that we continue to track. The latest variants have not changed other than the fact that the EG.5 that we have been talking about the last couple of weeks continues to be the dominant strain at 20.6% of the cases that we're seeing are caused by EG.5. Wastewater surveillance is also a metric that we look at, and the XBB dominant strain is seen in the wastewater surveillance. So the good news with that is EG.5 is part of that XBB strain, and the anticipated vaccine that's coming in the next few weeks covers this strain. So I think you're going to see much better coverage with the vaccine going forward. So certainly more to come. For those of you who have probably heard me say this, this is National Immunization Awareness Month. CDC has some great promotional materials that help promote routine vaccination and up-to-date vaccinations for all vaccines for adults all throughout the year. And they have some really great promotional posters that you can download. I'll pop the link into chat, but this certainly helps your vaccine efforts now and throughout the year. And that's it. Back to you, Josh.
Thanks so much, Mary Ellen. So at this point, I'd like to pass it over to Dr. Nadia Mujahid, who is going to go through her disclosures and begin with the presentation. Over to you, Nadia.
Thank you so much. It's an honor to be here. And these are just disclosures that does not impact anything that I'm talking about today. Next. So the reason I'm here is is this topic worth discussing in the post-operative patients? We are going to review some common surgical procedures in the US. We will review the most common post-operative complications, and then we will discuss some strategies to help prevent or treat complications. Next. The reality is that adults age 65 and older are the fastest growing segment of the US, and the number is expected to increase to 89 million by the year 2050. What we know is that the older surgical patients are prone to developing postoperative complications, functional decline, loss of independence, and other untoward outcomes in comparison to younger patients. I would mention that one of the most common, patients, post-surgical patients that we take care of in the skilled rehab facilities are hip fractures. And although the number approximately is 330,000 in the year now, the number is expected to increase by to approximately 550,000 by the year 2040. Next. So this lists basically the top most common surgeries in the US. It goes from cataract removal, which is approximately 3 million, all the way down to C-sections and circumcisions. But if you look at the next slide, please, you will actually address that most commonly we take care of these patients in the rehab skilled facility. So majority of the joint replacement may actually go home after surgery with home physical therapy, but a few complicated patients may come to rehab. We definitely take care of a lot of hip fracture patients in the rehab setting, as well as cardiac bypass surgery. Again, just to give you an idea of what we are dealing with here. Next. So now I'm going to shift gears and really focus on strategies for postoperative management and what are the most common complications. Next. So this basically gives us the most common complications. And, it could range from acute kidney injury with a serum creatinine, which is rising, to acute blood loss anemia. It could be atrial fibrillation, which might be rapid. It could be constipation, hypotension, malnutrition, postoperative fever, pressure ulcers, tachycardia, urinary retention, or wound infection and dehiscence. I'm missing a lot of the other complications. I just wanted to make sure that we address the most common complications here and things that we should be aware of and watching for. Next. So the basic guidelines of postoperative care is mainly to focus on these few handful. Pain control is very crucial in these patient population, but we need to also address things like hydration and nutrition. We really need to address mobilization as well as sleep hygiene. Delirium is another really common postoperative complications that we address, as well as really focus on medication management, care planning, and advanced directives. Next. I'm only going to mention a couple of the most common complications, and I'm happy to have any questions if you guys have any. So we should all be anticipating postoperative hypotension. The reason is that, once the patients go for surgery, no matter what type of surgery, they have general anesthesia and they have a lot of fluid balance. They may lose a lot of blood, or they have some IV fluid hydration shifts, whatnot. It's not uncommon for patients in the post-surgical world to have a lower blood pressure. It doesn't have to be in the 90s systolic, but more in the low teens. It could range from 100 to 110 systolic blood pressure, and there is no reason for us to resume all of their home blood pressure medications at that time. Sometimes these medications might not even be resumed until, a couple of days to even a week after surgery. So what can we do to anticipate and to prevent? We should be adding all blood pressure medications should have holding parameters on admissions to the rehab. We should be looking at hydration status. So if the CNAs are coming and telling us that the patient are skipping meals or really not eating and drinking, we need to go back and encourage as nurses and other members of the healthcare team to go in and encourage increased fluid intake. If the blood pressure remains low, despite us holding the blood pressure medications, we should think about checking orthostatic vitals to see where the patient is with the different position changes. If the patient is having anemia, it's reasonable to recheck to see if the anemia is worsening. And if it's severe anemia, which is less than 7 or downtrending, we might have to arrange for either an outpatient blood transfusion or send the patient to the emergency room for a blood transfusion. We should really be encouraging patients to have oral intake of fluids, and it's very common for patients not to like drinking fluids like water. I generally will offer them some kind of nutritional supplements just for a different taste, like Ensure supplements or Glycerna or any supplements that you may have in your rehab facility. If the blood pressure still remains lower despite doing all of the above, we might have to make a clinical decision about giving intravenous fluids, which could be either through the intravenous access or even through subcutaneous, which is Clysis. Next. Going from hypotension, it is very common that they kind of go sometimes hand in hand. If somebody has ongoing low blood pressure, they might also have an acute kidney injury, but it's not necessarily present in all the patients hand in hand. If the patient have rising serum creatinine, I would like you all and remind us to review all the medications and adjust by renal dosing. This is especially true for patients who might be on antibiotics for an infected prosthesis joint, in which the joint is infected and they need antibiotics for 4 or 6 weeks. We should be looking at the medications and stopping all nephrotoxic medications like ACE inhibitors, non-steroidals, diuretics, and ARBs as well. We should be stopping all hypoglycemic agents. And if we are doing all of the above and the patients are on insulin, we should be mindful to reduce the insulin dose, because if somebody is having acute kidney injury, they're not metabolizing the insulin as quickly as normal. And if it's not being metabolized, it's in the body, which means that they might have hypoglycemia if we keep on with the usual dose and the usual frequency of insulin. We should consider checking a post-void residual, which is a bladder scan, because a urinary retention in post-surgical patients is not only common, but it's also a common reason for acute kidney injury. Again, as I mentioned, with hypotension, we might have to consider giving fluids either through the IV fluids, through the IV access, or lysis, which is subcutaneous, in poor PO intake, rising creatinine. And we should be thinking about when to recheck labs. You know, if the patient came back with labs with a rising creatinine, plan when to recheck the labs. Rechecking the labs maybe the same day might not be helpful, but rechecking it the next morning after maybe encouraging oral intake or giving some fluids might be more helpful, just to help keep the patient stable, but also to help figure out what the trend is with the labs. Next. I cannot emphasize more on pain management. I think in the rehab skilled facility and older patients, it is something that is very important, and it's extremely necessary not only to provide the comfort, but also to have other complications like delirium. You know, non-pharmacological measures like eyes, elevation, position changes are often overlooked. And I would like a moment to remind all of us to use these in addition to pharmacological measures. You know, giving ice bags to the prosthesis or to the surgical site on for 20 minutes, then take off, maybe several times a day, really helps reduce swelling and provides comfort to the patients. In addition to that, I would encourage us to maybe consider doing scheduled acetaminophen up to 1,000 milligrams 3 times a day. So a maximum of 3,000 milligrams or 3 grams in any geriatric patient who is more than 70 years of age, unless there's a contraindication to using acetaminophen. We can use opiates for breakthrough pain, and I prefer using the lowest possible dose for the lowest possible time. In general, I usually use oral oxycodone 2.5 or 5 milligrams for moderate or severe pain every 4 hours. I generally would have these patients on it for the next couple of days, maybe a week. If the pain is well controlled with this, I do not adjust the dose. Sometimes we have to go up on the dose, while keeping in line that the patients are not getting very sleepy or sedated. Remember that opiates are great when used, you know, for appropriate time. So again, this is only for the next couple of days or 2 weeks while they are in rehab. I would also remind us to consider using opiates, you know, maybe half hour before physical therapy, because it really will help increase the participation in physical therapy. Consider scheduling low doses of oxycodone or opiates. I keep on saying oxycodone because that's one of the medications that I generally use, and I'll tell you why in a second. But if you are using oxycodone or any opiates, and you're taking care of a patient with severe dementia, consider scheduling a low dose once a day or twice a day, because those patients are still in pain and they are suffering. However, they might not be able to advocate for themselves. And we want to give them the benefit of providing them comfort, especially before physical therapy or changes while they are getting changed in the morning. I would avoid non-steroidals in the geriatric patient population for various reasons, but to name a few is because they might contribute to, acute kidney injury. Most post-surgical patients are on DVT prophylaxis, and that might be increased risk of bleed or GI stuff. And then also, I avoid using combination narcotics like Percocets and hydrocodone or Vicodin, mainly because I'm using scheduled doses of Tylenol as baseline at maximum doses. Next, I would mention one thing with pain medications. In pain management, while we are using the opiates and other pain medications, it is necessary for us to remember that while treating pain is important, we have to make sure that we also know that opiates do increase the risk of falls, and we are being, there's a risk and benefit to that medication. So talking about delirium, I will just mention few lines about delirium. Post-operative delirium is extremely common. It's as high as 15 to 53%. And a lot of times when these patients are discharged from the hospital to the rehab facility, they might still be delirious and might not be back to their baseline. If they were started on antipsychotic in the hospital to help treat the acute delirium, it is our responsibility in the rehab to assess those medication, but also aim to lower the dose, wean them off, and completely stop them if they no longer require those medications. Next. This slide basically talks about causes of delirium. And I will not go into a lot of details because next week you are actually getting a 20-minute, mainly a topic for acute delirium. So I will not address this, but I just wanted to share with you that some of the things that we can do in the rehab setting that commonly affects post-surgical patients are looking at their pain, looking at the medications, and then doing things like removing all the tethers. So if they do have a Foley catheter, evaluate when the Foley catheter can be removed and do a trial of void. It's also common that sometimes patients might not be delirious when they got admitted in the nursing home or rehab section, but now they are having waxing and waning mental status, which is delirium. Then we should be really looking at what changed, if it's a new medical diagnosis that caused the delirium, and try to figure out the reason and try to treat it. Next. Again, as I mentioned, anticipate post-operative delirium and, orient the patient as soon as possible and often. All the CNAs, nurses, therapists, anybody going in the room should be orienting the patient. Have a family at the bedside or over the phone if the patient is not listening, just to get their attention. Treat any reversible causes. And as I mentioned, look at medications. If they were on chronic psych medications or chronic opiates before they went to the hospital, it's reasonable to continue them. But again, avoid restraints and mittens, be patient with the patients, reevaluate and treat pain. Next. So again, very commonly seen in the rehab setting is tachycardia. A lot of that might be because of untreated pain. So look at the trend, look at the heart rate, but also don't forget that another reason is acute blood loss anemia. Some of these post-surgical patients are sent out from the hospital with a downtrending hemoglobin, and they might have downtrended even further. So check for labs, look at the anemia, and make a decision whether the patient needs something else. Patients who are dehydrated or have low intravascular volume, again, can lead to tachycardia, as well as fever. If the patients, looking at medication is crucial because sometimes the beta blocker or the calcium channel blocker that might be their home medications might have been accidentally stopped in the hospital, or did not carry over to the COC and were not resumed in the rehab status. So take a look at the medications. Of course, we have to look at infection as a cause, if somebody is having tachycardia. Again, for tachycardia or rapid AFib, evaluate the patient and treat the underlying causes. Next. So this slide basically shares about other common complications and how we can evaluate and treat them. Atelectasis is very common in post-surgical patients, and that's because a lot of these post-surgical patients are laying in bed in the hospital. Even after surgery, they might not be, getting out of the bed as frequently as we would like. When they come to rehab, they might still be sleeping a lot more. So having them do frequent and regular incentive spirometry, getting them out of the bed with every meal of the day is really helpful to prevent atelectasis. Constipation is extremely common again, not only in patients who are on opiates, but generally on all post-surgical patients, because even if they're not on opiates, they're really not walking and doing all the things that they were doing before. So think about starting all patients on valve regimen on admission. You can always stop them or make them as needed if they continue to have more frequent bowel movements. If the patients are having dysphagia, really assess and take a history whether this is acute or this is chronic. Did they have dentures which never came to the rehab facility? And if they don't have a chronic issue, they don't have dentures, it's acute, do a speech evaluation and then think about therapy. This is not to say that it's acute dysphagia and we are thinking stroke. And obviously, if that's the thing, you will obviously send the patient to the ER. If the patients have hyponatremia on labs that were done in the rehab, think about the other causes. It could be because they might be on chronic psych medications or they have chronic diuretics. Look at the patient and their nutritional status. So if their BMI is low or they just look cachectic with loss of temporal fat pad, they have skin on bones, think about how to increase caloric intake. You can add any boost or any nutritional supplement just to help increase caloric intake. If the patients have, they're really malnutrition by definition, then their protein intake should be somewhere between 1.2 to 1.5 grams per kg per day. Having a dietitian see them in the rehab is a great idea. In addition, I generally would recommend that if the family is involved in coming in and they have certain dietary preferences, it's okay to have them bring home-cooked meal just to help increase the oral intake and caloric intake. Again, this depends on the facility restrictions too, but this is generally what I generally do. If the patient is having aspiration pneumonias, again, we will think about precautions, small bites, chin tug, having speech follow the patients, and then also a family discussion to see if this is an ongoing issue or, okay, let's watch for now and do all these measures and see if this continues. It is very common to see patients with pressure ulcers. If they are, they might have been on the floor for a couple of hours before they were discovered and they had surgery. So again, pressure ulcers should be evaluated at the beginning on admission to the rehab facility. Frequent repositioning and increased protein intake are some of the things that we really need to address. And again, wound care. If the patients are having urinary retention, think about opiate medication, especially if they were recently started. Think about constipation, because if the patients are constipated, they most likely will have urinary retention. It could also mean that they had BPH and the medication somehow did not get through and they were not resumed on their BPH medications. If the patients are being suspected for urinary tract infection, I would encourage us to really increase hydration, oral intake. If you're sending a urine analysis, please send in a urine culture if the patient is symptomatic. Just sending a UA is not enough. Next. So other important consideration, Anticoagulants are generally used in the post-surgical patients to help prevent DVT prophylaxis, to help prevent DVT and PE prophylaxis. And they are extremely important to review in the rehab setting, not only to review the risk and the benefits, but also because the patients who are at risk of having DVT and PE are also at risk of having bleeding. But using them is important in the postoperative setting. I would suggest that when patients are on anticoagulants or any patient who's being admitted to the rehab, they should have a new care plan addressed that talks about DVT prophylaxis. How long are they going to be on DVT prophylaxis? Because sometimes they're on it for 14 days and sometimes they might be on it for 30 days or 3 months, depending on the cause and the reason. And I would remind all of us that all members of the team, the nurses, the CNAs, the physical therapists, should monitor for any complications like bleeding, which is common, even can happen without a fall. So think about anticoagulants, think about patients who are on it, and do our care plan for this. Opiates is another thing. And the reason I mentioned that is we are talking about post-surgical patients. And sometimes I've seen that patients and families are very reluctant in using opiates in the elderly patient population. I would educate them and remind them that we are using the lowest possible dose for the shortest possible duration, just to keep them comfortable and to increase their rehab participation. If we are starting opiates, we have to make sure that we address the acute need and take them off the opiates as soon as possible, once they don't have pain and they're not using a lot of as needed medication. We have to also think about if somebody is on opiates to make sure that we are not starting the patients on benzodiazepines at the same time. Not that we would, but if the patient is coming to the rehab facility with benzodiazepine, just be cautious and try to talk to the patient and family about weaning and not giving these medications together. Last but not the least, in the rehab facility, it's important that all patients have Narcan ordered, even if they're not on opiates, because sometimes medication errors happen and somebody else's opiate may be given to a roommate who was not on opiate, and it's good to have it ordered regardless. In the rehab, as well as nursing home and long-term care facilities. Next. So one other thing that we might address, it's all great when the patients are doing well and they get discharged to rehab, but we have to also think about unexpected complications and decline. Hip fracture, for example, I'm just using a hip fracture example. They have a high mortality at as high as 20 to 24% at 1 year. So, think about these patients are really high risk and may have bad complications. So we should be keeping the communications open with patient, family, giving them updates on what's being done. If they are not doing well or we are suspecting an infection, what are we doing for labs? Are we doing any imaging like chest x-ray? What are the treatment plan? When will we see the patient and what should we expect? Educate the patient and answer questions, but do not give false hopes because sometimes patients do decline and it's time to really have more like end-of-life discussions. I would discuss realistic plan of care, like tests that can be done and what time frame the results are available in the rehab facility. For example, the rehab in which we go, the blood test stat orders the results are reported back to us within 4 hours. However, we cannot arrange for a blood transfusion in the rehab facility. And again, we need to let the families know that this is subacute setting, so not as acute as a hospital where everything and anything can be done. We should have a low threshold in consulting palliative care in patients for goals of care discussion and advanced care planning, especially if the patients are complicated and declining and the family might have unrealistic expectations. All members of the team should be updated with any change in condition and should be able to provide accurate information to the patient or family. Doesn't matter if they are, just filling in for that day. Doesn't matter if they're coming in the evening or whatnot. Communication is extremely important in our patient population. Next, and I think that's my last slide with questions. Oh, actually, take-home points. So again, just a snapshot. We discussed how the adults age 65 and older are the fastest growing segment of the US population. Older surgical patients are prone to developing post-operative complications, functional decline, loss of independence, and other outcomes in comparison to younger patients. Anticipating complications and being proactive will help prevent complications and improve outcome, which is preventing hospitalization, for example, or even an ER evaluation, if you can do the labs and the test in time and quickly. Clear and open communication between patient and families are crucial in developing trust and providing phenomenal care. I would also mention that if the patient was a long-term care resident in your facility, went to the hospital for some kind of urgent surgery or a hip fracture and is now coming back as a skilled patient, it is very important that the nursing home staff does a completely new care plan addressing all the acute needs, which would address, obviously, DVT prophylaxis, pain management, and then other things, maybe even restrictions. Some patients are weight-bearing, some patients are not weight-bearing, and all those. Thank you so much for your time.
Thanks so much, Nadia. I have the references and resources that are part of the slide deck that will be available to everyone once it's published on our website. And at this point, I'd like to turn it over to the audience. Does anyone have any questions that they'd like to ask Nadia?
I have a question, Nadia, about pain management. Noticed recently over the last few years that gabapentin is being used by the surgeons a lot post-operatively. Like your thoughts about how you manage that?
Oh, thank you, Lynn. I put a cheat sheet to myself that I should mention, and I totally forgot. So thank you for bringing it. So in the past, it was felt that if patients, post-surgical or pre-surgery, if patients are getting gabapentin, the other name of that medication is Neurontin, that will treat the pain and help reduce the opiates that the patients are using. However, recently, 6 months ago, a meta-analysis came out that actually addressed that the gabapentin or Neurontin use did not necessarily reduce the opiate use, however, increased the risk of delirium in these patients. So what I'm doing in my hip fracture patients, I never started gabapentin, to be quite honest, but if I sometimes am covering other surgical services at Rhode Island or at the Miriam Hospital, where we generally do consultation and co-management, I usually would address with the orthopedic surgeon. It's generally used in elective joints in the hospital system that we work as. And we generally would say, don't start a patient on this because it really does not reduce opiates and increase delirium. And we don't want that. That's generally what I'm doing.
Thank you.
Sure.
So we do have a comment from Charity. Thank you. It was very informational. And I have another comment from Tiffany saying, will there be slides available? So, yep, slides will be available for this presentation. I can send them out to everybody after the session, and we will also be able to put them on our series webpage that you can access the material there as well. Not seeing anything else in the chat at the moment, but here's our contact information. If you have any questions, anything you'd like to add, or need any additional support with any other of your quality improvement initiatives, we can assist you. You can see our contact information for our iPro team here. Last call for any other questions before we end the session for today. All right, not seeing anything, and nobody's come off mute. So that'll be it. We do have a replay of this session tomorrow at 3:30. So anyone who missed out, be sure to tell them to come check out this same recording again tomorrow at 3:30. And then we do have our IP3 sessions on Thursday at 11. If you thought that today was a good use of your time, just please leave us a note in the chat. It does help and mean a lot to help inform our future presentations. So would appreciate any comments that you could leave on your way out. Well, that'll be it for today's session. Thank you so much for joining, everyone. I hope you have a great day. Thank you.